So glad you could join me for the lesson on multiple sclerosis. Welcome.
Anybody recognize this fine face right here? Montel Williams, the famous host of daytime TV. And how about this guy here? I know we all know who she is. This would be Jack Osborne. Both of these people have MS. Yep. Both of them were diagnosed to have MS, and this disease is the leading cause, actually, of neurological disability in young adults, where normal life takes for it. They're trying to live normal life, and unfortunately, this disease takes forever to diagnose because symptoms are very, very vague, such as fatigue, weakness, and vision changes. A lot of times patients are just told that they need to get more sleep and they need to, just de-stress their life. But in all actuality, they have MS. In fact, initial findings can be so vague that a person is not diagnosed for several years. And patients find this distressing because you basically have all of these problems, nobody can give you answers, and you just feel like you don't know where to turn. It's very depressing, actually. This disease has the stages of going through relapses or exacerbations. In fact, the most common form of MS is the relapsing and remitting. You can live a normal life, like you actually, if you manage it well, you can get to a normal life expectancy. However, it must be managed well. The disease can progress, and the durations and frequencies of the multiple sclerosis flare-ups can become more severe over time. I don't think you guys really need to know the different types of multiple sclerosis, but their name implies their meaning in general, such as the relapsing and remitting MS. It's the most common, so we'll kind of focus on that one. Anybody can think of another condition that has periods of exacerbation in the neuromuscular system? ALS? And try again. How about myasthenia gravis? Ding, 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 ding. Very good. All right. So this right here is a 48-year-old female, lives in Massachusetts. Anybody want to take a guess who she is? Oh, I'm actually forgetting her name. It's Mitt Romney's wife, Mrs. Romney. She was actually, like I said, diagnosed at 48, but typically people are diagnosed 20 to 40 years of age. They will live in colder climates, so maybe that can help you remember. She lived in Massachusetts, that's why I put her picture here. The Northeast, the Northwest, that's a cold climate, and the Great Lake region is where they do see a lot of cases of MS. They're not really sure, but they think it could be viral. Not really sure. It has been shown to be genetic, where if your first degree relative gets it, you may also get it. There are a lot of different factors that trigger relapses in this condition. Some of them, they're listed in your book, but believe it or not, physical injury, say you have like a trauma, emotional stress, pregnancy can trigger this, kind of like MG can be triggered by pregnancy, so can MS. Overexertion, temperature extremes, like if it's super hot, even getting in a shower, like a super hot shower or like a sauna, they can have an MS exacerbation. And like MG, if they have a virus or an infection, they can have another relapse of multiple sclerosis. MS often, excuse me, MS often looks like a couple other neurological diseases, such as like chronic fatigue syndrome, thyroid disease, syphilis, maybe even spinal cord compression. this is kind of why it makes the diagnosis so difficult. But early on the disease, we'll see something called Udhoff sign. This is a temporary worsening of vision, and it only occurs when patients have exerted themselves or in situations where they're exposed to heat. That's called Udhoff sign. So it's a temporary worsening in the vision. It's kind of important. Now, fatigue is the most debilitating manifestation of MS, and unlike other patients, fatigue is associated with temperature, like they get too hot or even too cold. Fatigue is the most debilitating manifestation, and it's associated with temperature. Patients will have pain or paresthesias, especially in their lower extremities. This is why they think it might be a spinal cord compression problem. They'll have double vision, scotomas. Anybody want to take a shot at what scotomas is? This is when they have decreased peripheral vision. Well, changes in peripheral vision. It's usually decreased, but they'll have changes in peripheral vision. They'll have decreased visual acuity, like it will be really hard to see something, and they'll not be able to discriminate. They can discriminate colors, but from one object to another. Nystagmus, this is whenever your eyes kind of jitter a little bit to the right and to the left, so they'll have nystagmus. Another early signs and symptoms of multiple sclerosis is muscle spasms. So they'll get really twitchy and have pain associated with this. Now, we will also develop something called scanning speech. Scanning speech is whenever you have these long pauses in between the words or these syllables, and they will continue to stop at certain places. I promise there's nothing wrong with your connection. I was just giving you an example of scanning speech. So we need to make sure to be patient with these people because they will talk in certain parts. So, scanning speech. Now, we will, in addition to have scanning speech, slurred speech. Excuse me. Dysphagia, mood changes. Who else has mood changes? Was it MG or ALS? If you said ALS, you are correct. Another thing that's interesting is they'll have intention tremors. So this is when their hands, when they're at rest, have no tremors, but as soon as they try to reach for something, they'll start to shake and tremor a little bit. And they can be fine or coarse tremors. They will have bladder and bowel dysfunction. Excuse me, gosh. Do you remember what other disease has bowel and bladder dysfunction? How about MG? Good, you got it. At least I hope you did. And that would be late MG, people who have later stages of diseases. They also will appear clumsy, just like our people who have ALS. As you notice, I'm trying to draw some similarities and I'm trying to explain the differences. So you'll be able to understand this disease, from the other ones. Sometimes it can help a little bit in trying to study and learn all this. Alright, and here in late changes, we're actually going to start having some cognitive changes. People are going to have memory loss, impaired judgment. They're going to be very difficult actually to be around in the later stages of multiple sclerosis. Let's see. And impotence. They're not going to have a problem with libido. Libido is going to be fine. Their sexual drive is not affected. For this disease, there is no conclusive lab test. Diagnosis is solely based on clinical findings, maybe some imaging or laboratory findings. So when they do a lumbar puncture, their cerebral spinal fluid may show some white blood cells and even some protein. And if they were to check a total immunoglobulin level, it might be elevated. They can do a head CT. This is going to reveal some plaques in the head. And if we were to do an MRI, which is the most sensitive, that goes right here, it's the most sensitive diagnostic test method for detecting this disease. It's going to show active plaques inside the brain. We can do an electromyography again, but this may be grossly abnormal. But I mean, it's going to show abnormality, but it only is useful in people who have the advanced form of the disease. This was the bad bladder and bowel problems I put a picture there of. All right, so you need symptoms, you need a CT, MRI. All right, multiple sclerosis complications. Remember, they had that dysmetria. Anytime you know dysmetria is a problem for the disease, such as an ALS or MS, injury from falls is huge. Injury from falls, they're going to fracture their hip, and then we're going to have to do a total arthroplasty of the hip, probably through an open reduction. Put it all together for you. UTIs, that's going to be a common problem with these people. Constipation as well, because they're not going to have good bowel and bladder movements. Probably their food choices are going to be poor as well, since they can't swallow. Pressure ulcers are going to actually be a problem with this group. Sexual impotence, because remember, they have no problem with libido, only function. Optic nerve atrophy, their visions are going to get worse and worse. They may even become legally blind. This is through multiple exacerbations, by the way. Just throw that out there. They can have emotional liability and depression. This is very challenging for family members to have to try to, support this person as they're going through all their multiple. One or more drugs are recommended for multiple sclerosis. Drugs are used to treat and control the disease, also to decrease specific symptoms and to slow its progression down. So what we have here on the left-hand column are drugs that were given to help try to modify the course of the disease, particularly this interferon beta 1A, or Avonox. The first dose is usually given under medical supervision. Reason being is that they are likely to have a reaction, such as an anaphylactic reaction under the first dose. So they're given, at the doctor's office. The rest the person gives at home. For both of those, really, we need to make sure the person reports the signs and symptoms of infection. This one I've seen, actually, it is the first med that's approved orally for multiple sclerosis. And we wanted to monitor the pulse for about within the first 6 hours of giving this drug. And the reason being is it can cause, as you see here, bradycardia. Also can suppress the immune system, kind of like the others. Now, I kind of don't want to go into all of these, but we give IV steroids. We're at risk for, breaking bones. With taper doses, you're not allowed to stop steroids immediately. Laxatives, just because they have constipation problems, they do have spasms, so let's give them some baclofen. Are those drugs again? They keep coming up, huh? Ooh, we can give baclofen intrathecally. In fact, when a lot of patients, not a lot, some will actually get a pump that's implanted into their body, and it will give slow doses of baclofen over time. Your spasms have to be pretty bad, just saying, to get the pump. A lot of times you just take a pill. All right, depression. This one right here, this is an SSRI. This is great for the pain that they may feel and the emotional labileness. Oxybutynin, this is a anticholinergic, and if you know anything about anticholinergics, You have to watch for this side effect. And I mentioned it before, but the side effects are can't pee, can't see, can't spit, can't shice. But the bladder incontinence that patients have, we can give them this drug here. The big thing is that it doesn't go too, the drug doesn't work too much on patients. It can happen. It can. So, to assist this person, frequent rest periods is the name of the game, because fatigue is their most debilitating symptom. We need to avoid overworking and de-stressing their life. Aerobic exercise is actually very effective. This right here is actually a painting of some visual imagery listed here, which can help with pain management. Distraction can also help. In fact, I know a couple of times, you use this by not even thinking about it. You'll turn on TV, you'll talk to people, and sometimes they can forget about the pain that they're in. We can give them electrical nerve stimulation, such as a TENS unit, that can help with the spasms. Localized heat, do make sure that we put a barrier between their skin and the heat. This is for the muscles achiness that they may. Some other interventions we can do is basically monitor and manage the symptoms. We may eventually need a wheelchair for this person. So at some point, they're going to lose their ability to walk. Maybe. Behavior problems are completely common, so teach family to work with the person and even maybe do nonverbal signs or cues when a person is behaving inappropriately. The speech language pathologist can definitely help with swallowing, picking and choosing directions for them to turn their head. We want to remove scatter rugs. Everything must be clutter-free because they have dysmetria. Now, if their bladder incontinence is bad, we can obviously do the one drug. They may have the other extreme of bladder retention. We can do self-catheterization, teach them how to do it, or even put in a pacemaker. And they are at risk for UTIs, don't forget about that. So a lot of times they'll do prophylactic antibiotics. That means antibiotics. Cognitive behavioral therapy, this has shown to be very productive for patients with MS. Use scanning techniques. Now, they're going to have scanning speech. Remember where they talk in little patches of words and syllables? However, scanning techniques is supposed to be for vision impairment. In fact, see this here? This teaches a person to look across the room and find different things, or they can kind of do like an X pattern. So teach a patient to use scanning techniques, and this is to help with their scotomas, their peripheral vision problems. We're going to implement eye patches. This is actually very useful for blurred vision. It actually kind of solves it really easy, and it helps the one eye be dominant and be used for seeing versus both eyes trying to see things. The occupational therapist is usually the one who initiates this. Sexual counseling for the impotence. We may even have a patient discuss the prosthetics or a stimulation device. Avoid temperature extremes, hot showers, super cold days, and a person needs to kind of diary. Last but not least, diet interventions. Maintain a nutritional management program. They're going to be constipated. Let's look at getting some fiber in their diet. Thick liquids. They can't swallow, well, at least at some point they're going to have swallowing problems. Let's make sure that their liquids are thickened. They can get it down better. Foods need to have gravy on it. They need to be pureed maybe at one point. And worst case scenario, we need to be giving somebody PEG tubes. They need to know the signs and symptoms of being too full. You know, they're going to have a little bit of diarrhea maybe from the tube feedings. Put some fiber in there. This is the diet we want them on: high fluid, high fiber. That's what we need to walk away from this diet interventions: high fluid, high fiber. Okay, everybody, thank you for listening to the PowerPoint. If you have any questions, feel free to use the discussion board, and you can email me, or you can do both. At some point, somebody will answer you. Hope you have a great evening, and I will be reaching out to you guys later.
I recognize that you're a student with a lot on your mind and a lot to do, and you're a very busy person, so I'll let you get back to whatever you need to go do now. Toodles!